So, hello
Um,
everyone. Welcome back to Med Talk, where we dive into the latest breakthroughs and innovations shaping the world of medicine. Today, we have the privilege of speaking to Dr. Barth, the Director of Liver Transplantation and Associate Director of the University of Chicago Medicine Transplant Institute. This is a conversation you don't want to miss. So, welcome, Doctor, and we are glad to have you with us today.
thank you.
My first question is, can you share with us your journey to these two leadership roles and what they mean to you?
Well, yeah, thank you. It's really a privilege to be able to talk to you and your audience today. Um, I am the co-director for the Transplant Institute at the University of Chicago. I'm a professor of surgery and a surgeon who does kidneys and pancreas and liver transplants as well as other operations. The University of Chicago is a really special place in the history of transplantation
Mm,
with a long history. Uh, in goes back over 100 years. In 1904, Alexis Carrel was at this institution learning and doing some of the first work of how to sew blood vessels together.
yeah,
That work actually won him a Nobel Prize and was kind of the basis for how we might be able to sew organs into people. And then it took another 50 or years before we could actually do this successfully in patients in the world. Um, in the late 80s, the University of Chicago was the first institution in the world to do the first successful living donor liver transplant
yeah,
from a mother to child, and that patient is still alive and doing well. And
wow,
then in the recent era, in the 2000s, we've really been growing multi-organ programs for lung, liver, kidney, pancreas, hearts, and specializing in really complex multi-organs and have done a large proportion of the global experience in these most complex triple organ transplants.
yeah.
So I got to Chicago about 5 years ago. I've been in practice for over 20 years. Um, and the program has really been growing really quite nicely. The city of Chicago, which you can see in the background here, is the third largest city in the United States. So a lot of patients
Mm,
that come from our city, but a
mm,
lot of patients from around the United States to get some of the treatments that we offer that aren't available at other transplant programs,
yeah.
and a lot of patients who come from around the world to
Oh,
get
wow.
treatments
Yes.
that aren't available in their own home countries.
Mm,
And that's kind of always been our position in the field of transplantation, is to be really, offering cutting edge, innovative approaches to organ transplantation to complex patients that may not have that access
yeah.
at other places.
So we know that liver and kidney transplantation have evolved significantly over the years. So what are the most breakthroughs or groundbreaking advancements you've seen in this field?
I think that there's multi kind of faceted developments that are moving in parallel right now.
Mm,
Um, in the transplant community, we talk a lot about robotic transplants, and they're in the Middle East and Saudi Arabia is the global leader in Riyadh for robotic liver transplantation.
mhm,
Very impressive work that's being done. In North America, we really entered an era of machine perfusion of livers that keep these organs alive
mhm,
after they've been donated by someone who's passed away. And that's really exploded in the last 24 months. And
mhm.
our center is heavily involved in these, what we call normothermic machine perfusion, both clinical trials and clinical use. It's allowing us to use more livers than ever before to help people get transplanted.
Mhm,
Um, we as a center that's been committed to living donor transplants for decades,
mhm,
we're now using kind of that expertise to help patients with new types of cancers that previously we didn't think could be cured by transplantation. And this new era of what we call transplant oncology is offering liver transplants for people with metastatic colorectal cancers to the liver, people
uh-huh.
with aggressive bile duct or cholangiocarcinoma cancers. And we're kind of exploring again what are the new approaches that can really save lives through offering living donor transplants to some of these people.
So
Um,
you mean that an organ that is has cancer, you can remove it and replace it with the transplant?
Correct, exactly right. And so,
Yeah.
there have been a lot of advances in control of solid organ tumors and
Mm,
interventional radiology and shrinking tumors, a
yeah.
lot of new drugs and checkpoint inhibitors and drugs that control but at a certain point, there's tumors that go only to the liver
Yeah.
and really can't be removed without removing the whole liver. And
Liver,
so,
yeah.
based on the advances in the other areas of oncology, we've been able to now expand access to transplantation.
Mhm.
And for the most part, that means people need living donors.
Yeah.
It needs a lot of expertise in oncology. So our oncology tumor boards with medical expertise.
Yeah, so
And
there are many challenges still exist in encouraging more people to become living donors. Uh,
yeah, I mean, I think
yeah, this is
it's
how can we overcome this?
well, I mean, I think it's got a differential approach throughout the world. So
Mhm.
in Riyadh, Saudi Arabia, they're the largest living donor liver transplant program in the world right now.
Yeah.
And I think that patients know and families know that in order to really get a liver transplant, bringing a living donor is really critical.
Hmm.
Uh, and that's been a successful approach. But it's balanced by the relative difficulty in getting deceased organs, that
Yeah.
people who've passed away, that it's difficult to coordinate national systems through
Mhm.
every hospital in a country, that when someone is a possible organ donor, to get them to donate. So um, the United States, while we did the first series of living donor liver transplants,
Mhm.
certainly other areas in the world have really taken over the volumes and the ways to get donors.
Mhm.
We I think still struggle to balance that. The living donor operation for living donors is one that historically was, had a major operation to remove a piece
Yeah.
of liver. A lot of advances in minimally invasive
Yeah.
laparoscopic and robotic techniques are making this safer and less invasive to hopefully encourage people to donate. And then really the vast majority of all livers transplanted in the world come from people who have passed away and who are
Yeah.
brain dead. And that really relies on national systems that are developed to encourage organ donation from people who might be possible
And
donors.
the outcome is the same if you have like a living donor or a deceased donor.
I think our center experience and probably globally would suggest that the outcomes are probably a little better for living donor.
Yeah.
So
Yeah.
we used to tell patients the reason to get a living donor is so that you didn't have to wait on a list
Mhm.
for someone to pass away to donate an organ.
Yeah. Hmm.
But actually, while that is a real benefit that you can schedule and get a transplant before you get deathly ill, the
Yeah.
other benefit is that your outcome is generally better. And there are many reasons that may play into that, but certainly one of those is that it becomes an elective surgery
Yeah.
that the teams can plan for. Surgical anesthesia, critical care teams get a lot of preemptive notice to make all of their appropriate planning.
Mhm.
That we know the donor who's donating the organ, we've studied it, we've done X-rays and blood work,
Mhm.
um, versus the system of deceased organ donation. And
Mhm.
again, at different centers in the United States and the world are function differently. But at our center behind me, over two-thirds of the patients who are getting transplants are literally sitting in the hospital waiting for their transplants. They're too sick to be at home. Half of them might be in the intensive care units, the other half just in hospital beds, too sick to be discharged. And when we're transplanting people that sick, they have more complications and risks of surgery.
Mhm.
Whereas living donors almost universally are coming in from home for scheduled transplant and are a little bit more robust to go through that major surgery.
So, doctor, you were talking about the minimal invasive surgery for living donors, kidney
Yeah,
or liver.
yeah.
So, what are the techniques and how does it help improve the donor outcome?
Well, so I've been talking a little bit mostly about the minimally invasive techniques that have been, recently in the last couple of years really developed for liver donation. For
Mhm.
kidney donation, kidney transplantation is by far the most common type of organ transplant that we do in the United States and across the world. Kidney donation minimally invasive techniques were really revolutionized in the late 1990s when people converted from making big open incisions to
Mhm.
laparoscopic skills. The
Mhm.
technique that we use at University of Chicago is called a single port or various other names,
Mhm.
laparoscopic and single site surgery.
Yeah.
Um, but we make a small little incision in somebody's belly button and put multiple instruments through the single site, do the
Mhm.
entire operation. The kidney, which is about as big as someone's fist, gets removed from the belly button. And when we close up and shrink the belly button down, it's an incision where really just a band-aid goes over, or half a band-aid. And we've
Okay.
done almost 800 of these over the past decade. And that's, really encourages people when they see that they can donate an organ, a kidney, and have just a band-aid when they
Yeah.
wake up and go out of the hospital the next day.
And
That,
the
that
side
these
effects are minimal.
it is major surgery. We're very
Yeah.
careful as surgeons. We work with our medical colleagues, social workers, nurses, pharmacists, experts outside of just the surgical practice to really make sure organ donors understand the risks of surgery. They get the quote unquote $1 million workup to make sure there's no medical issues or reasons
Yeah.
that they won't be healthy after donation. We give them a lot of education
Mhm.
about, what the process of healing and recovery is. It
Okay.
is serious surgery, and we really make sure that these people are well aware. It's heavily regulated in the United States and around the world. Every donor gets registered through the United Network of Organ Sharing to make sure that their safety is being looked after.
Okay.
Each center is required to have 2 years of follow-up and checkups with these donors to make sure any issues and are being dealt with and reported as well. So
Mhm.
it's really one of the most important special things we do, but we're the most cautious about the safety of those living donors.
And doctor, how do you see artificial intelligence and robotic surgery influencing these kinds of surgery?
A great question. I mean, I think this is kind of a year of artificial intelligence,
Yeah,
and I
yes,
think that
in every
it,
issue.
every issue it's kind of
Yeah,
like what could we be doing better, more efficiently, and
AI.
I think is there are two thoughts and schools of thought potentially on some of these things, that surgery is a technical field, that robotics and potentially the ability to use artificial intelligence and existing imaging studies, that the surgeries can become automated and potentially be somewhat performed without a human operator behind it, is
Mhm.
something that people have talked about for quite some time.
Mhm.
As a surgeon who operates, not every day, but every week doing
Yeah,
transplants, um, every patient I operate on is different. And those differences aren't always demonstrated on CT scans
yeah.
or MRIs, that each human body has a little bit different response. the,
Mhm.
the response of a biologic organism, it's not like a car engine where robots can put always the same pieces in the engine and make thousands and tens of thousands of cars, because every human body responds a little bit differently. And I'm sure AI at some
And
levels
I
will
think
be
even
able
the
to.
anatomy of every patient is a little bit different from the other.
Exactly right. And
Yeah,
even different than what the imaging study shows, and
yeah.
the texture and the quality and the integrity of the tissues, those really can't be demonstrated. So
Mm.
I think it's likely that these things will help us become better and safer at surgery. Uh, Kind of like when we drive our cars right now, we kind of
Yeah.
forget all the extra things that are, added to make the car driving more safe.
Yes.
But at a certain level, I think a human operator is still,
Mm.
where we'll be for the immediate future.
Maybe
The,
it
the,
helps in
the
diagnostic more than when you do technical surgery.
maybe diagnostic,
Yeah.
and maybe when things are kind of getting complicated, there
Yeah.
may be some algorithms to help that as well. But it is exciting, and I think that in the future, medicine has disruptive innovation moments where something gets introduced and really changes,
Mhm.
because patient safety is so important.
Yeah.
I mean, it's kind of like air travel around the world, that when we operate on a human being, that we're not willing to necessarily take new risks, that
Yeah.
when we have a very safe system. So it may be a little slower in medicine because of the importance of patient
Mhm.
safety.
And doctor, can we talk about the immunosuppressive therapies? What are the latest promising drugs? Because we know every transplant patient has to take like therapy throughout his life. I mean,
Yeah.
so what are
And,
the
and that's
latest in this? Yeah.
and that's been kind of, again, the first successful transplants. And even decades ago, we used to say people would wake up and have to take a handful of medicines
Yeah.
every day, dozens of pills. Some patients right now just take one or two pills twice a day, and that's all they need. There are new categories of drugs that were introduced in the last 5 and 10 years where they only get treatment once a month. There are new approaches towards immunologic tolerance where some patients don't even need any immunosuppressive drugs.
Hmm.
The field of transplantation has always been very tightly linked to development of these new immunosuppressive drugs. And there's new clinical trials for different classes and targets of immunosuppressive drugs that are in process right now that I think as those get approved will open up kind of even better and better therapies. In
Hmm.
general, the field has gone away again from requiring patients to require so much medications to more simple and lower levels of immunosuppression. And I think that, that's likely where we continue that regardless of what specific drugs we use, we're generally trying to be a little bit more tailored, personalized, and hopefully a little simpler for the patient to
Hmm.
get their medications.
And what are your insights into the latest developments in xenotransplantation and how close we are of using genetically engineered animal organs and
Well,
human
we are right
transplant?
there. We are there and we are ready to do it. I started as a university student doing some research in this in the late 1980s, early 1990s, and I had done research in my postdoctoral years up at Mass General doing this in the late 1990s. I've been doing work in the 2010s in this. Those
Yeah.
were all in animal models and large animal models to
Mhm.
see what barriers we were overcoming. The last few years have been very exciting in the United States that we've seen the first clinical efforts on heart transplantation and kidney transplantation.
Yeah.
Um, just this week, the US Federal Drug Administration announced that they were approving these organs for the use in clinical trials. And the
On
two
humans, you mean?
in humans. So
Ah,
that's just breaking news as of just a
wow.
couple days ago. And so two of the major private companies that are developing these transgenic pigs, and these are all from pig organs that have been genetically modified.
Hmm.
So there'll be clinical trials in the next year in humans in kidney transplantation. And
Uh-huh.
then there's also some exciting stuff with the livers and the hearts that these pigs have that are the most compatible they've ever been with humans. And we just, again, had a press release in the last week of a patient from New York that's
Uh-huh.
now been 2 months with a successful pig kidney that's working and keeping them alive. So it's a very exciting era. And this is something that's kind of we expect in transplantation that something that's been investigated in the laboratory for years and decades, suddenly there's kind of a little breakthrough and it suddenly starts to be, feasible and possible. So we're entering this first phase of clinical trials for xenotransplant. It's very exciting. And
Yeah.
we're going to be involved in those here in Chicago.
We heard about like kidney, like engineered kidneys. Is it true?
Well, I mean, truth is something that's not, I'm not, I don't know
Can we
truth,
have
but
like a machine instead of a kidney?
organ bioengineering is something that people have been working on. And
Yeah,
this again is research in the laboratory where people have
still is.
taken organs from animals or other people and taken out the cells from those organs
Yeah.
and put in new, healthier cells or cells like the patient's. There's also the idea of using three-dimensional printers to make organs or tissues that could be transplantable.
Hmm.
Um, and so this field of bioengineering of organs, whether we're using pre-existing scaffolds of other organs
Yeah.
to repopulate and make cells of the potential new organ, or we're actually printing and creating, artificial structures that are getting functional
Hmm.
cells for whatever organ we're trying to make. This is something I would predict will be involved. It may relate to some of the xenotransplant field. It may
Yeah.
kind of independently develop, but again, it's something that for now is mostly in the laboratory. It's not
Yeah.
yet in clinical trials, but again, an exciting area that in my lifetime I expect to see in patients.
Hopefully. So, doctor, your lab has worked on composite facial and limb transplantation. What are the biggest challenges in this field?
This is complicated. The first
And
human,
do you think it will become widely available or
I mean, I don't think it'll be widely available, but
Mhm.
the first surgeon who did the successful kidney transplant was a plastic surgeon who
Yeah.
really wanted to do skin transplantation for severe burn injuries in the 1950s, but they just could never work because skin always rejected.
Mhm.
And with developments and advances in medicine, we've discovered we can overcome that.
Yeah.
So the first successful hand transplant patient is now over 25 years out with his hand transplant.
Hmm.
Uh, a face transplant, the most comprehensive face transplant done, I still think globally to date, was done by our team. And that patient is 13 years out with a successful face transplant. But there's very low volume of these cases. There's
Yeah.
some centers in Europe that are doing hand transplantation. The
Mhm.
US has a new consortium of centers that's going to be doing some face transplant work. Um, the idea of the parallel advances in robotics and prosthetics,
Mhm.
offer competitive therapies for hand transplantation.
Yeah.
Facial transplantation, there's a lot of good plastic reconstructive techniques, but
Mhm.
there are some patients that exist that have such severe injuries and defects that
Yeah, they
really
need
a
skin.
single operation that can fix all of their damaged tissues, still has a role. I think, it's an area that has limited application because of these other good therapies. But for
Mhm.
certain patients, it's very important that these approaches exist.
Mhm. So, in your opinion, how do you think transplantation will look like in the next decade?
That's a good question. I mean, I think we'll be doing more transplants. I think as transplant providers and surgeons, sometimes, we think that managing disease that make people sicker as
Hmm.
people get older and managing heart disease and lung disease and kidney disease and liver disease, they may have to stop working. It's expensive. It causes families lots of, effort and expense. That if we can replace diseased organs earlier,
Hmm.
um, that this really, can change the health of patients, that could avoid a decade or longer of managing the failing diseased organ. The
Hmm.
limit to that has been the limit of how many organs are available, and that we just don't have enough organs. In
Hmm.
the United States, we have over 500,000, close to 600,000 Americans on dialysis for kidney failure, and we're only doing 26,000 plus kidney transplants a year. If we had more organs, whether they were from animals, bioengineered organs, encouraging more organ donation, the goal would be we could help more people with
Hmm.
organ failure
Hmm.
move to a point where they have a functional organ and can be living robust, full lives, doing everything, working, being productive members of society. So I think that simply put is the goal, is to kind of help more people through organ transplantation. That's a bit dependent on getting more organs to transplant.
Great. And doctor, do you think governments should do more in I don't know, in helping and I don't know, maybe doing like campaigns to make living donors more willing to.
Yeah, I think living donation and deceased donation. Deceased
Yeah.
organ donation is incredibly, important. There are a lot of people who pass away
Hmm.
who could donate those organs that could save 7 lives, sometimes even more.
Yeah.
And, in the United States, we have a very good system of organ donation through the United Network of Organ Sharing.
Yeah.
I think in the Middle East, they're developing organizations that are really focused on
True.
developing new systems to help with deceased organ donation. There are countries in Europe that really lead the world with this as well. Um, and I think that public awareness is critical, because when somebody hears these wonderful stories, we just had a transplant a couple months ago of a sister who donated a piece of her liver to her younger brother. And, saved his life. And
Yeah.
these stories go on the media and people hear about this and they're just so emotional and amazing.
Yeah.
And that public awareness of what somebody can do to literally give a piece of themselves to save a life is that public awareness, whether the government, private organizations, the medical establishment does it. It's sharing that message it's a wonderful message. And the
Yeah.
more people hear about it, it really does encourage more people to think about what whether they would donate an organ if they had a terrible accident,
Hmm.
or even if they were alive and wanted to donate a kidney or a piece of a liver. And it doesn't have to be to a relative.
So,
It
yeah.
it can be to somebody that is a friend that's
Yeah.
not blood related. It can even be we have people who walk in again in our university behind us with professors and graduate students and undergrads. Sometimes we get people who walk in and say, I just want to donate a kidney to whoever needs it most. And
Wow.
so the education and the awareness really do encourage people to think
Yeah.
about this.
Thank you, doctor, for your time. It was a very informative interview. And hopefully we'll see you again for another interview also.
Great. Thank you. Appreciated the time to chat with you.